But typically one of the things you're going to see is they will pre-treat, and they better pre-treat her next time.
She went to a small hospital that is basically historical, so they didn't tell her that. So since I worked at that arthritis clinic, I told her, I said, you need to take some time to go.
Yeah. So definitely you want to do that. Now, one of the things that I'll tell you is that they found bisphosphonates. They are not without some long-term consequences. Okay, even though these are given to build up bone and to help prevent fracture, one of the things that they found is that women that were on Fosamax, Beniva, and Actonil, for a while, there was an increased incidence of femur fracture while walking. Just random out of the blue femur fracture. Okay? Don't know why. But it does occur in 1 to 2% of women that take these medications. Now, Reclass, or the zolaninic acid, one of the things that you will see is that it can cause osteonecrosis of the jaw. So typically what they will tell folks if they're going to put these people on the medications is to have any dental work that you need to have it done before you go on these medications. Because you don't want someone working on that jaw while you're on this medication, because it increases your risk of osteonecrosis of that jaw. So people that have change in the fit of their dentures or jaw pain, it needs to be checked out. The other thing is that there is an increase in incidence of AFib with women with these medications, or men with these medications. Most adverse affection events are going to occur within the first 3 months of starting. Now, this medication, or calcitonin, is given to women at least 5 years postmenopausal. And then typically they don't give it after that 5-year period. Miacalcin is given sub-Q, or Fortical is given intranasally. It's like a nose spray. Couple of things you need to remember about this. If it's given intranasally, they need to alternate nares, because it can cause some irritation and submucosal breakdown. So they need to alternate so that they don't get that buildup up in there. Basically, one of the things that you're going to see is that it is approved by the FDA for treatment, but not prevention of osteoporosis. So this would be on a medication that someone would be on that is already been determined that they were osteoporotic, not someone in that osteopenia level. The Benevas, the Avistas, the Fosamax can be given to someone for prevention. So someone in that osteopenic category could be given those medications to prevent osteoporosis. Pain reduction, orthotic devices. Think about splints. Think about corsets. Think about supportive devices. One of the things that I will tell you that you need to be very, very careful of, if you have these little ladies that have been diagnosed with osteoporosis, always, always, always use a lift sheet with them when you're pulling them up in bed. You know how sometimes you grab them under the arm and one person on either side and pull them up that way? You might hear pop, okay, where you've broken their arm. So always use the lift sheet with them. Careful movement with these patients, because minimal trauma can cause a fracture. Now, one of the things that you will see done to help with pain control for women that have suffered a vertebral injury is kyphoplasty or vertebroplasty. You may hear it referred to as either. Basically what they will do is they will do a surgical procedure, often done in radiology, because the patient does not have to be asleep. What you've got is a little lady that's collapsed her vertebral body, and they've got, remember, the nerves come out in these little foramen, okay? And so they've got pain related to that foraminal compression. So what they do is they take a probe that has a balloon on it into the vertebral body. Then they blow the balloon up, and then they squirt cement into the hole that it made. And what it does, it's like jacking a house up for the foundation, okay? Making a repair and then taking that probe out. So what you get is this vertebral body that no longer is collapsed, and it's got that bone cement in there that supports that vertebral body. And therefore what it does is it relieves the nerve pain caused by the compression. What you see on x-ray is this. See right here where this vertebral body, it almost is wedge-shaped. Okay? And you can see this one, but see how close it is over here versus over here? Now look after the kyphoplasty. Basically what you've got is a much wider vertebral body, and that way it will help control pain. Now what this does is it not only controls pain, but it keeps these patients up and moving. Typically what you will see is that after the kyphoplasty, they're able to get up, they're able to walk, they're able to do their exercises in their ADL. Often they will do these as outpatients. Sometimes they will do them as inpatients if the patient's diagnosed with that vertebral fracture or vertebral injury while they're in the hospital. If you ever get a chance to go see it because it's really sort of cool. But typically what you will see is these patients have a decrease in pain. They have a decrease in their inability to function, and they have an increase in mobility almost immediately. And that bone cement stays in there and it's permanent and keeps that vertebral body expanded. Now, are there questions about osteoporosis? Remember that I said drugs are fair game. I included some reading, I think, in your book, your pharmacology book. Just make sure you read the section about the anti-osteoporosis medications. All right. Back problems, fractures. This is a nice fracture. That one would hurt like crazy, and that probably caused a lot of bleeding into that person's thigh. Okay. Anyone in here strain their back during at work or in clinical? Pretty much. Anybody that will continue to strain their back in clinical, everybody can raise their hand, because nurses are one of the most common occupations with back injuries. Okay, it's fairly common. It's typically attributed to activity, movement, and often improper bending. Okay, one of the things that we as nurses do is remember, keep that bed in a low position, but raise it to save your back and then put it back down in the low position. Because if you're leaning and over that patient, you're not using good body ergonomics in order to prevent injury to your back. A couple of conditions can cause back issues. Pregnancy is probably the number one that we see in young females. Even before the labor pain, that back labor starts. I mean, think about your center of gravity. It's been thrown off. Your gait has changed so that back issues can result. Posture and sleeping habits. You know, one of the things that you see is that if you sleep, you know, you wake up, you feel these twinges. Oh, I slept funny. You didn't sleep funny, haha, you slept funny, weird. So what you often see is that poor posture, slumping down in your chairs, leaning one way or the other can cause back issues. Physical condition and degenerative disorders. Remember, as we become more and more sedentary, it basically decreases the support that our abdominal muscles have and our lower back muscles have to support and prevent injury. Bad workplace ergonomics. I know that if you work at a hospital, you have to do that work ergonomic thing every year. And still, do they change the way that your computer is set up? No. You're lucky if you get it set up. I mean, before I had my hip replacement, that was one of the things that I made them do. I said, my chair does not go up and down and stay up. You have to fix my chair. It'll cost $350. That's okay, I'll bring you a doctor's note and you can buy me a new chair. So I got a new chair. So, but you need to make sure that you try to do it as ergonomically as possible. It's like with those computers on wheels that we have at Northeast, okay? You know, I see a lot of people doing this as they're pushing it down the hall. It does go up and down so that you can see over it to get in the room. And then if you need to bring it up so that you can see, you can do that. But trying to barrel down the hall with it in the up position, you're going to, it'd be like bowling pins, the people in the hall. Typically what you will see is what we call referred pain, and that may be due to nerve injury or the back injury causing what we call referred pain. Think of sciatica, where you have pain that goes down your butt and goes down your leg, okay? Same with cervical injuries. If you've got pain here, you may also see numbness or tingling in the arms or pain. Okay. Now, probably one of the things that you'll see most often as a problem, besides sprains and strains, is what we call a herniated disc. Okay. Lay people may call it slip disc. Typically, you will call it, it's a herniated nucleus pulposus. But no one people look at you funny when you say that. So a herniated disc. What happens is that those intervertebral discs are shock absorbers, and you have rupture of that cartilage surrounding the disc. And what happened is that the gooey center sort of squishes out. I don't know if any of you remember that gum that used to be called Chewels or something like that. Whenever you bit into the gum, the center would squirt out at you. Yeah. Think of that as what a herniated disc is like. If there's a rupture in that outer edge, the gooey center sort of squeezes out. It can occur spontaneously or from trauma. It can be abrupt or gradual. As our bodies age, that discs become less able to absorb the shocks because they lose the fluid content. As we age, those discs tend to dry. And that squishy center is not so squishy anymore, and it sort of shrinks. They slip out of place more easily as we age. Typically what you see here is that cartilage ring that's around that intervertebral disc, and this nucleus pulposus typically squirts out, and that's what causes the problem on those nerve roots. Okay? It's not that the disc herniated and the vertebral bodies are on each other, though I've seen that. It's the squishy center on those nerve roots. And with this myelogram, you can see that. Typically what you don't see done very often anymore is myelogram. We use MRI because it gives us a much better picture with less problems for that patient. Classic, we see recurrent episodes of pain in that lower back. We may see sciatica, and that is usually what we see with pressure on the nerve roots, L4, L5, S1, S2, S3. Now, you may see postural deformity. Basically, they lean to the side of the pain because that way it doesn't stretch and hurt as much. You may see motor deficits. Eventually, what will happen is that they may develop what we call foot drop, which means that that foot is in a dorsiflex position and they're unable to bring it back up. Okay, so they may have to have a splint for that. Basically, what you will see is that changes in reflexes. The patellar reflex decreases, that ankle reflex decreases. Often what you will see is not only motor deficits, but you'll have sensory deficits. And typically you have sensory deficits before the motor deficits. You have numbness and tingling in that extremity. Now, think about this. L4, 5, S1, S2, S3. Anybody have any idea what, other than walking, what other types of things that, especially S1, S2, and S3 control? Urinary function, bowel function, and sex. Okay? The three biggies. Okay? So typically what you may see here is people that are may not be able to control bowel, bladder, or sexual function. Often what you find is that typically these people retain urine and they are constipated. They have problems going. Okay, because that micturition reflex goes to that spinal cord, but it doesn't get back when that bladder senses that it's full. Okay? So those are things that you might see that also cause a problem. Not only do you have the sensory problem, but if they're on opioid pain medications, it's going to be further compounded with that opioid constipation. Now, some of your clinical manifestations: intermittent pain, lower extremity weakness, unsteady gait. You may see muscle spasms. Urinary elimination problems and altered sexual function. Often you will see hyperactive lower extremity reflexes. Diagnostically, what we do is x-rays and CT scans. we've already talked about. We also will do EMGs, electromyographic studies. We're looking at nerve conduction to the muscles. Typically, pharmacologic therapies is analgesics, mild analgesics and NSAIDs, muscle relaxants, and maybe sedatives. Okay? Though they're backing off of those a little bit more unless this person is having severe muscle spasms. Typically with back pain, okay, even if it is caused by a herniated disc, we try conservative therapy first. Unless they're starting to have motor deficits. Typically 2 to 6 weeks of conservative therapy. And then what we do is reassess, and if they're still having the same signs and symptoms, then we would often do surgery. Now, what is conservative therapy? Well, conservative therapy may be alternative and complementary therapy, chiropractic care. Not the bendy, snappy, twisty chiropractic care, but a chiropractor that does massage therapy. They may do ultrasonic stimulation. Okay? Basically, chiropractors, if you look at the research and you find a good chiropractor, they are just as effective as surgery in some patients. The other thing is massage therapy, especially if these patients are having muscle spasms. Now, we don't want to go to Massage Envy, though. That's a good place to go if you just want to relax. But you want a physical therapist that is specially trained in massage for these types of injuries. Okay? Acupuncture. Acupuncture has been shown to be as effective as opioid analgesics for low back pain. It's also very effective to help with some of the physical problems, like it hurts when I move my leg, okay, versus pain when I lie still. Acupuncture or acupressure are extremely effective. The other thing that they found, and this has just come out in the last week, guys, is that yoga is just as effective as physical therapy for the treatment of low back pain. Basically, they looked at yoga versus physical therapy. There was no difference between the two. What they did find with both of those is that both groups took less pain medication than people that were just educated about low back pain. Now, it used to be with low back pain, what you did is that, I'm sorry, you need to be on bed rest for 2 weeks and take this pain medication around the clock. But we don't do that anymore. The best thing that you can do is start walking, start going to therapy, or start doing yoga. Okay? But you don't want to go to any type of yoga. Okay? You want to go with someone that's been specially trained to work with people with low back pain. And it doesn't matter if it's hot yoga or regular yoga. I don't think. At least the study showed that both types were equally as effective. But walking and exercise, yes, I know you hurt, but take your NSAIDs and start walking, because that's what's going to help you. with that conservative therapy. A lot of patients are able to avoid surgery, and unfortunately, a certain percentage are not able to. So what we do with them is surgery. You might see what we call minimally invasive surgeries. Those are the microscopic endoscopic discectomy, or the microdiscectomy, or the laser-assisted laparoscopic lumbar discectomy. Yeah. MIS, minimally invasive surgery. Basically, these are the ones that you see on TV. My incision was only an inch. Versus to open, or not the microsurgeries where you may have a 6-inch incision. Okay? Now, when I first started nursing, this was back before the days where nobody cared how much you spent, even your insurance or Medicare. Oh yeah, you need that. Let's get it while you're in the hospital. Okay? What we would see is that patients would come in and have their lumbar laminectomy. They come in the night before so we could do pre-op teaching, which was a wonderful thing, except whenever you had to admit 13 people and you felt like lining them up and doing a class. But they would stay in the hospital day of surgery, and then maybe up to 6 to 7 days after their surgery. Now, lumbar laminectomies are often done as an outpatient procedure. They come in the morning of surgery, they have their surgery, here are your list of instructions, go home and walk. Call me if you have fever. Basically what you're going to see is that only the patients that have spinal fusion are the ones you're going to see in the hospital. Now, spinal fusion is different because what you often see with the laminectomy is that they would take part of the lamina off, get rid of the herniated, no, they don't stuff it back in, they cut it off, the nucleus pulposus. Then they make sure that you have good stability of your vertebra, and then sew you back up. Now, spinal fusion, typically what you will see with a spinal fusion is patients that have instability in their spine, where you have movement. So typically what they do with a spinal fusion is they take a bone graft, often from the hip, and make a hole and plug that bone into that hole to sort of fuse them together so that there's no longer movement. You know, typically there's movement in the cervical vertebra, there's movement in the lumbar vertebra, the sacral vertebra are fused together normally. Okay? I typically will see back pain in that cervical area or the lumbar area because of that movement. I typically don't see laminectomies done for the thoracic vertebra because there's no movement. Why?
Because you want that stable, because it's where all your vital organs are.
That's where your vital organs are, and what are protecting your vital organs?
Your bones.
The ribs, okay? The ribs keep those thoracic vertebrae from moving. Yes, and what would you?
When they do the plate in the neck, is that considered like a spinal fusion?
It is. They often will do bone grafts. Sometimes they will do screws and plates.
I saw one where they put the screws in plates.
And basically what you've got then is a person that's going to have to do their neck like this to turn, because it will not turn up and down.
But even when you put screws or plates, you have to put a graft in or it won't harvest.
Yes, that's true. And I'm going to tell you, every one of these patients that I've ever taken care of complain more about their donor graft site on their hip than they ever do about their neck, because it hurts more. Because if you think about it, they cut the butt muscle to get to it, and it hurts more than their neck does. Because whenever you walk, you use that muscle more than you do use your neck muscle. Now, the other thing that you will see post-operative, like I said, those minimally invasive surgeries are done outpatient. Most of your laminectomies are done outpatient too, with the exception of the fusions. Those are usually in hospital because of the chance of complications, especially if you're doing a cervical fusion. Because if they do a cervical fusion, most of the time they'll do it anteriorly. And what sits right here? Your airway. And so if you get swelling or bleeding, then you've got possibility of a compromised airway. Now, laminectomies, this is what we teach them. Pain control. You need to take your pain medication when you need it, not just because it's every 6 hours. Log roll. One of the things we want to do is keep that spine stable. So what we want them to do is to turn like a log, which means that when they turn their entire body, not reaching over and grabbing the rail and then turning, okay? You want to stay as straight as possible whenever you roll. Vital signs every 2 hours, if they're in hospital. If they're at home, you don't worry about that. Voiding is one of the things we do worry about though. Okay, remembering if we're getting near that sacral area, we want to make sure they void before they leave the hospital. And we need to make sure that they void in a position that's comfortable for them. If you have to have someone use a bedpan, this needs to be the fracture pan, because you don't want them on that full bedpan laying in the bed. Okay? Men need to stand up to pee. So typically with my gentlemen, I get them up to the side of the bed, log roll them to the side, and then help them up and let them stand to urinate. Had a guy tell me, oh, it's not time for me to pee yet. Yeah, you've had 1,000 cc's in of your IV fluid. He says, no. I've got a 12-beer bladder. I said, okay. So I said, you've got until such and such a time, and then I'm going to have to catheterize you. He says, give me some fluid. Sure enough, he had a 12-beer bladder. He put out 1,200 cc's. I said, this is not good for your bladder to do it this way. He says, but that's the way I've always done it. I said, well, as you get older, it's going to give you problems. But anyway, he would